Go ahead, Dr. Again.
Good. Good morning, everyone, and welcome to Tyro MDS. Welcome all of you for a session that I have been looking forward to for quite some time now. This morning's program really features three individuals who are household names in the world of thyroid cancer. For those of you who are listening in this morning, I would encourage you to take every possible opportunity to send in your questions. I will do my best to make sure that I get to them before the end of the hour. So leading us off this morning, I'm presenting a paper which I really encourage everyone to read. It is a great summary, even though it is 2 years since it was published. It does provide a great deal of information that's incredibly valuable to understand where we've come and where we may be going. And that will be presented this morning by Dr. Lori Wirth, who is the Elizabeth and Michael Reen Endowed Chair of Medical Oncology at Massachusetts General Hospital. She is the medical director of the Center for Head and Neck Cancers, as well as co-director of the Advanced Thyroid Cancer Clinic at MGH. She's also widely recognized for her expertise in the management of advanced thyroid cancers. She has led large clinical trials that have helped to shape the contemporary management of advanced thyroid cancers. She is also an incredibly valued member of the Thyroid Advisory Board. As two discussants this morning, I couldn't have picked two individuals who can provide just tremendous perspectives based on their contributions as well as their expertise in the field. Dr. Eric Sherman is an associate attending at Memorial Sloan Kettering Cancer Center in New York. He's a member of the Head and Neck Solid Tumor Service, as well as specializing in the management of advanced thyroid cancers. And Dr. Naifa Busaidy is a tenured professor at MD Anderson Cancer Center, where she focuses her clinical and research efforts on advanced thyroid cancers. In addition to her numerous national and international society leadership positions, she has led the many clinical trials that have greatly impacted thyroid cancer management. She is widely published in thyroid cancer literature, and she is also, as well, an extremely valued member of the Thyroid Advisory Board. And so with this, I'm going to turn over the program to Lori Wirth. And again, I would like to encourage all of our listeners to send in your questions, your comments, and look forward to a really exciting and informative hour here. So Lori, thank you for your presentation as always.
Well, Mark, thank you very much for such a kind introduction. And it's great to see everyone and be a part of this discussion. And I just really appreciate the opportunity. So this is the paper that we're going to be discussing, Progress in Treating Advanced Thyroid Cancers in the Era of Targeted Therapy, that was published in Thyroid in 2021, written in collaboration with Carrie Cunningham, Peter Sadow, my very own favorite Dr. Gil Daniels here at Mass General. And I have to confess, I did do some updates because I couldn't resist. Here are my disclosures. One of the things that was published since that paper was published was this paper by David Shanka in collaboration with the American Head and Neck Society and ITOC, trying to get at what is our idea of advanced thyroid cancer, because this is a phrase that we used a lot. And this paper, I won't go into detail with this long list, but basically, I think this paper really kind of captures what we're talking about when we think about advanced thyroid cancer. So it's not just REI refractory progressive differentiated thyroid cancer and anaplastic thyroid cancer, but also those patients who present with very bulky, invasive, perhaps inoperable or unresectable differentiated thyroid cancer, medullary thyroid cancer, patients with distant metastatic disease, and so forth. Basically, patients in whom we may want to consider systemic therapy. And so, as we now know, thyroid cancer really is rich in potentially druggable targets. And that's why thyroid cancer really is such a cool field in this day and age. So these data, I think, are well known. Papillary thyroid cancer is the most common cancer, but across the spectrum of thyroid cancers, there are potentially druggable gene alterations that are the driver alterations. So BRAF V600E is most common across thyroid cancers because papillary thyroid cancer is most common, but we also see oncogenic kinase fusions. One of these days, we're going to be able to drug the KRAS and RAS mutations that we see in follicular thyroid cancers. One of these days, we'll figure out how to drug oncocytic thyroid cancers better. And of course, not shown on the slide is medullary thyroid cancer, but with RET mutations now, medullary thyroid cancer is a whole new field. And I show this in honor of Eric. This study was published from Memorial Sloan Kettering several years ago now, looking at their solid tumors that were studied in by their NGS assay. And I highlight this just to show that in more than 10,000 tumors that were studied with the MSK Impact NGS assay, thyroid cancer was second only to GI stromal tumors in terms of solid tumors harboring potentially druggable alterations. So if you're thinking about precision medicine in oncology, you want to be thinking about thyroid cancer or advanced thyroid cancer for sure. And also, if you're thinking about drugging fusions related to causing cancer, you definitely want to be thinking about thyroid cancer. So this analysis of the solid tumors across TCGA showed that thyroid cancer actually harbors the highest rate of all solid tumors studied in TCGA for harboring oncogenic kinase fusions. So RET fusions are the most common, but we also see NTRK1 and NTRK3 fusions. ALK fusions can be seen as well. BRAF fusions can be seen, not quite druggable yet, but I think we'll be getting there in the future. So if you're thinking about fusions causing solid tumors, thyroid cancer really should be the first solid tumor that you think of. And we're learning a lot about these kinase fusion positive thyroid cancers. This is just one paper that has shown that there really is a unique histology and unique natural history for kinase fusion positive thyroid cancers. We took a look here at Mass General at all of our differentiated thyroid cancers that harbored oncogenic kinase fusions identified here. And our pathologist, Peter Sadow and others, found that there is a characteristic histologic triad in these fusion positive thyroid cancers where we see prominent multinodularity, fibrosis, and extensive lymphovascular invasion. We see higher rates of extrathyroidal extension, lymph node involvement, and distant mets as well. So Peter and his colleagues here do our fusion assay when they see these features in a cancer as part of their diagnostic workup now. So let me talk about treatment. We've had good drugs available in our arsenal for a decade now to treat advanced thyroid cancer. The first era of drugs were the VEGFR multikinase inhibitors, lenvatinib, cabozantinib, vandatinib, and sorafenib is not shown here, but these are kinome dendrograms where the tree shows all of the kinases present in the human body. The branches represent families of kinases, and then the leaves individual kinases. And then the balls on the graphs show the kinases that are inhibited by the various drugs and color-coded for which kinase is being inhibited. And so you can see that all of these multikinase inhibitors do inhibit a number of different kinases with prominent inhibition of VEGFR2, also VEGFR1, VEGFR3, but other kinases as well, including the RET kinase. And so these drugs are approved for treatment of RAI refractory progressive differentiated thyroid cancer. Sorafenib was approved by virtue of the decision trial, showing an improvement in progression-free survival compared to placebo in patients with progressive RAI refractory DTC. Lenvatinib was the second drug that was approved based on the SELECT trial, with a really great separation of the curves in terms of progression-free survival with lenvatinib compared to placebo, and very high overall response rate as well at 65%. And then for medullary thyroid cancer, multikinase inhibitors that are approved include vandatinib and cabozantinib, with similar study designs where the drug was compared to placebo with progression-free survival as the primary endpoint and significant improvements in progression-free survival. Of course, the downside to the VEGFR multikinase inhibitors is the adverse event profile. These drugs do cause side effects. These are oral drugs that patients take every day, and they take the therapy hopefully every day, week after week, month after month, hopefully for a number of years. These adverse events can be quite tolerable, but can add up over time. So hypertension, hand-foot syndrome, diarrhea, anorexia, nausea, weight loss, fatigue really can take a toll on patients over the months and years that people are on therapy. And then there are rare but potentially even life-threatening adverse events that can occur as well. Now, for most patients, the adverse events can be managed with dose holds, dose reductions, and good supportive care. But in the studies, decision, SELECT, and so forth, treatment discontinuation did occur anywhere from 12 to 19% due to treatment-related adverse events. So that takes us to more precision-targeted therapy. So for the first kid on the block was NTRK. So NTRK encodes for a neurotrophin family of receptor kinases that are uncommonly expressed in multiple tissues, but especially in the nervous system, in maintenance of the adult nervous system, but also in development. And NTRK 1, 2, and 3 are the genes that code for TRK A, B, and C. And basically what happens with these oncogenic kinase fusions is that the business end, where the 3' end of the gene here is in this example NTRK3 that codes for the intracellular kinase domain of the protein, gets rearranged with a 5' partner, here the example of ETV6, and that 5' partner leads to expression of this aberrant fusion gene, and typically codes for a dimerization domain. So that causes intracellular homodimerization and activation of the kinase by virtue of that fusion. And that usually leads to upregulation of the MAP kinase pathway and other oncogenic pathways. So again, when you think about fusions, think about thyroid cancer. Here with NTRK fusions, you can see that we encounter them across solid tumors at very low levels, but in adults, thyroid cancer actually harbors the highest rate of NTRK fusions. So these fusions are rare. They're even rare in thyroid cancers, but they're more common in thyroid cancers than in any other solid tumors. And I just want to show this diagram here. This represents the fact that NTRK1 and NTRK2 in particular are known to have multiple different 5' fusion partners. So here with this NTRK1, TMP3, TP53, and so forth. And so this is important when you're thinking about the assay that you're using to try to identify if your patient's tumor harbors an oncogenic kinase fusion. You need an assay that can pick up all these different multiple 5' fusion partners. So we see NTRK fusions very commonly driving very rare tumors, including nearly all infantile fibrosarcomas, but also in adults, secretory carcinomas of the salivary glands and the breast. And then, as I mentioned, infrequently in follicular-derived thyroid cancers, where we see up to about 5% of thyroid cancers harboring NTRK fusions. And we see primarily NTRK1 and NTRK3 fusions in thyroid cancer. So Larotrectinib was the first TRK-specific drug that was developed. And you can see here in this kinome dendrogram that there's potent inhibition of TRK A, B, and C, and very little off-target kinase inhibition. So Larotrectinib was studied in NTRK fusion-positive solid tumors in pediatrics and adults. And I'm going to show you some of the data from the pooled presentation of these separate phase 1 and phase 2 trials. So this is an updated report of 159 patients treated in the group of trials with Larotrectinib. And as expected, you can see that patients with thyroid cancer were the most common adult diagnosis that was enrolled in the Larotrectinib series of studies. And overall, across all of these different tumors, appendiceal cancer, lung cancer, salivary gland cancer, thyroid cancer, there was an objective response rate that was confirmed centrally of 79%. And look here in this waterfall plot over to the right, these are patients that had 100% decrease in the sum of their longest diameters or a complete response. So the complete response rate is 16%, which is really quite high, with a median progression-free survival of 28 months in these patients overall. So in terms of safety, because Larotrectinib is a more specific targeted therapy than some multikinase inhibitors, we really can see that in the safety profile. So this tornado plot here shows the treatment-related adverse events, and it's color-coded for the severity. So you can see that most are grade 1 and grade 2, with very little grade 3 or grade 4 treatment-related adverse events in the patients treated with Larotrectinib. And so only 8% of patients had to have dose reductions, and only 2% of patients had discontinuation due to treatment-related adverse events. So Larotrectinib was the first tissue-agnostic small molecule approval in oncology by the FDA. So let's drill down and look at the patients with thyroid cancer treated in the Larotrectinib trials. Steve Waxback from MD Anderson published this paper. And what you can see is that patients, the blue bars are patients with PTC or follicular thyroid cancer. And then the purples are poorly differentiated or anaplastic thyroid cancer. And the waterfall plot looks beautiful for the differentiated thyroid cancers with an objective response rate of 86%, but the objective response rate isn't as good in patients with anaplastic thyroid cancer, 29%. But when we look at the swimmer's plot, even the patients with poorly differentiated or anaplastic thyroid cancer who had a response generally progressed very quickly. So it looks like Larotrectinib is highly effective in patients with NTRK fusion-positive differentiated thyroid cancer, but not so good in patients with anaplastic thyroid cancer with a median PFS of just 2.2 months. Now, I'm giving the short shrift to Entrectinib and Repotrectinib, which are also both approved for the treatment of NTRK fusion-positive cancers. They have less data in thyroid cancer, but there are patients with thyroid cancer that have been enrolled in these clinical trials. And so please look at those studies. Now let's focus on RET. As you know, RET is a proto-oncogene that codes for the protein that can be activated in thyroid cancer in two different ways. In medullary thyroid cancers, we see RET mutations driving a majority of patients with medullary thyroid cancer. Those mutations are either germline, giving rise to MEN2A or 2B, but they can also occur somatically in the tumor itself, causing sporadic medullary thyroid cancer. And about 60% of sporadic medullary thyroid cancers do harbor somatic RET mutations. But then we also see RET fusions in about 10% of papillary thyroid cancers, causing intracellular homodimerization and constitutive activation of RET there, and that signals through MAP kinase pathway, PI3 kinase, and so forth. And both, whether it's a fusion or a mutation, both of those alterations give rise to ligand-independent signaling and oncogenesis in thyroid cancers. So now we have two specific agents that have been FDA approved targeting RET specifically, namely selpercatinib and pralsetinib. Both of these drugs were designed similarly to inhibit RET as hard as possible and have as little off-target inhibition as possible. You can see that there's a little bit of red there, a little bit of red there. So there is a little bit of off-target kinase inhibition with selpercatinib and pralsetinib. But both were designed to inhibit the wild type RET kinase that's present in the oncogenic kinase fusions that we see in thyroid cancer and non-small cell lung cancers and so forth, but also all of the RET mutations that are known to occur in medullary thyroid cancer, including RET V804, which we now know is an acquired gatekeeper resistance mutation that can arise in patients with RET-driven cancers treated with the RET VEGFR multikinase inhibitors. So I'm going to focus a little bit more on the selpercatinib data than the pralsetinib data, and I'll tell you why in a minute. Let me go through the Libretto 001 trial quickly for you. Libretto 001 was the first in human phase 1/2 trial of selpercatinib. There were multiple cohorts enrolled in this trial, including patients with RET fusion positive non-small cell lung cancer. There were also 3 thyroid cancer cohorts in Libretto 001. RET mutated MTC patients who had been previously treated with cabozantinib or vandetanib, RET mutated MTC patients who had not previously received vandetanib or cabozantinib, and then there were also patients that were enrolled with RET fusion positive follicular derived thyroid cancer. So let me show you the updated data that was published earlier this year in the JCO from the thyroid cancer cohorts from Libretto 001. So this busy table, which I apologize for, shows the side effect profile. This is called from the patients with RET mutated MTC from Libretto 001. And I circled the treatment-related grade 3 or higher adverse events to highlight that the numbers of grade 3 or higher treatment-related adverse events really are pretty low with selpercatinib, but not 0. So we do see some low rates of grade 3 or higher hypertension, transaminitis, or diarrhea. 30% of patients did have dose reductions due to treatment-related adverse events, but only 2% of patients had to have selpercatinib discontinuation due to treatment-related adverse events. And there were no grade 5 treatment-related adverse events or deaths related to selpercatinib in Libretto 001. I do also want to note that we can see prolonged QTc interval on selpercatinib, some peripheral edema, and ascites or also pleural effusions. Those are typically chylous in nature, which is really kind of weird and not understood, but things to be aware of when you're using selpercatinib. So this slide shows the updated Libretto 001 activity in previously treated MTC patients. So the objective response rate that was independently reviewed was 78%, with 13% of patients achieving a complete response. And these are patients that have been previously treated with cabozantinib, vandetanib, or both. So very good activity. In this updated data, we now have reached the median progression-free survival, which is 41 months in this previously treated patient population. And also we've met the median overall survival, which is more than 5 years in this patient population that's heavily pretreated in Libretto 001. And then, as it's expected, the activity looks even a little bit better in patients who are previously untreated, with an objective response rate of 83% and 24% of patients achieving a complete response when they're treatment naive, treated with selpercatinib. Still, the median progression-free survival and median overall survival have not yet been met from Libretto 001. And then in RET fusion positive follicular derived thyroid cancer, we now have enough patients to separate out the treatment naive patients and the previously treated patients. So the objective response rate is 96% in the treatment naive RET fusion positive thyroid cancer patients with a PFS that's not yet been reached, or median PFS that's not yet been reached. And then in the pre-treated patient population, the objective response rate is 85% with a median progression-free survival that's now been reached at 27 months. So it was on the basis of Libretto 001 that selpercatinib garnered an accelerated approval by the FDA for the treatment of RET-driven cancers, including RET-driven thyroid cancers. Following that, there was a mandatory phase 3 trial that was required by regulatory authorities. And so Libretto 531 ensued. This is a study that was a phase 3 trial conducted around the world. Eric was one of the participating PIs of the trial. And this study enrolled patients with RET mutated medullary thyroid cancer that had progressive disease who had not previously received any therapy for their disease. And they were randomized in a 2-to-1 fashion to selpercatinib versus physician's choice cabozantinib or vandatinib. It was a 2-to-1 randomization. It wasn't blinded, and the FDA did not require that because basically everyone knew that everyone would know what drug the patient was, what arm the patient was on. But when patients did have confirmed disease progression on cabozantinib or vandatinib, they were allowed to cross over and receive selpercatinib. So the primary endpoint of Libretto 531 was progression-free survival. So we now have just presented the updated data at the American Thyroid Association meeting. So let me show you the highlights here. This shows the median progression-free survival. You can see a wide separation in the curve compared to with selpercatinib compared to either cabozantinib or vandatinib. So in those other trials that I showed you, those were all active drug compared to placebo. This is active drug compared to active drug. So there's a highly statistically significant improvement in median PFS, where it's 14 months in the control arm and still hasn't been reached in the selpercatinib arm with a hazard ratio of 0.2. And one thing that's really interesting is that in the initial New England Journal of Medicine publication, the objective response rate was 69%. And I remember being kind of disappointed because that wasn't quite as high as what we were seeing in Libretto 001. But with longer time of follow-up, we're seeing that objective response rate increase over time. So the objective response rate now with further follow-up on the selpercatinib arm is 82%. So don't throw in the towel early if you're not seeing an early response. Be patient because some patients do take a while to respond. Now there was a novel secondary endpoint that was incorporated in the trial, which is treatment failure-free survival. And this is a composite endpoint that basically incorporates both progression-free survival, but also drug discontinuation due to treatment-related adverse events. So basically it captures how well do people do in terms of their disease control, but also being able to stay on therapy. And I really like this endpoint because I think that this is the kind of endpoint that really matters to patients a lot. And you can see that there's a wide separation in the curves where there's significant improvement with treatment failure-free survival with selpercatinib compared to the control arm of cabozantinib or vandatinib. And then we presented at ATA these updated overall survival data. And you can see that the separation in the curves with a hazard ratio of 0.28 has held up over time. And so on the basis of Libretto 531, selpercatinib did achieve full FDA approval for the treatment of RET-mutated medullary thyroid cancer. Now let me touch on the ARROW trial briefly. Pralsetinib was studied in ARROW, which was a similar phase 1/2 trial in patients with RET altered non-small cell lung cancer, RET altered thyroid cancers, MTC, and RET fusion positive thyroid cancer. This study showed significant activity of pralsetinib. However, the confirmatory phase 3 trial of pralsetinib in thyroid cancer was not launched. Therefore, the accelerated approval that pralsetinib initially received was voluntarily withdrawn for RET mutated medullary thyroid cancer. So I only show this these data here because pralsetinib did maintain its approval for treatment of any RET fusion positive cancer. So pralsetinib does remain available for RET fusion positive RAI refractory progressive thyroid cancer. And you can see here a very high objective response rate of 91% with a median PFS of 25 months. So pralsetinib is available here. Now, I'm just going to talk very briefly about the problem of gene-specific therapy, which is that it does work well, but it doesn't work forever, at least not in all patients. And what we have now seen is the development of acquired resistance in patients treated with selpercatinib, also with larotrectinib. And there's a common theme that has emerged, which is that you can see on-target RET mutations, such as seen here at RET G810, which is a residue in the solvent front. And so that's shown here that basically these RET G810 mutations block the drug getting into the kinase domain so that it can't shut down the kinase domain. And this is so interesting because these mutations are paralogous with other mutations that have been described in other settings, including ALK inhibited non-small cell lung cancer. However, the picture is more complicated than that, unfortunately, because what we're seeing is that patients treated with selpercatinib, pralsetinib, and so forth, is not only do we see on-target RET mutations causing acquired resistance, but we also see mutations and gene amplifications and even fusions have now been described in bypass pathways, including MET amplification, KRAS amplification, KRAS mutations have been seen. We've even seen, very interestingly, BRAF V600E mutations emerging in patients developing resistance on therapies like with selpercatinib. And not only do we see all of these different alterations causing acquired resistance, we can often see compound mutations in the same patient accounting for acquired resistance. And as you can imagine, that's a really difficult problem and a really difficult problem to drug. Now, there are next generation RET inhibitors that are being studied. There have been a couple of trials that have been in the phase 1 setting that haven't moved forward to phase 3. The trial that is open now with the next generation RET inhibitor in the phase 1 setting is a study examining EP0031. This was designed as a very potent and selective RET inhibitor that also can overcome the solvent front and gatekeeper resistance mutations, whether they're expressed alone or together. And as you can imagine, that's a really tricky drug that can do all of those things in a very small kinase domain space. This was originally developed in China, and there's good preliminary evidence of efficacy and safety in Chinese patients. And these are data that were presented recently at ASCO, showing that so far the early experience does look promising for EP0031 to move forward in further study here in the US, looking at patients with RET-driven cancers who've developed acquired resistance, particularly that gatekeeper resistance or solvent resistance. I'm going to talk very briefly about BRAF V600E. As everyone knows, we do see BRAF V600E quite commonly in papillary thyroid cancer, and then also fairly commonly when anaplastic thyroid cancers dedifferentiate into anaplastic thyroid cancer. And this here highlights nicely an anaplastic thyroid cancer arising out of a papillary thyroid cancer in IHC for BRAF V600E positive in both components of this tumor. And so it's so tantalizing to drug BRAF V600E in advanced thyroid cancers, with the drugs that have been developed primarily or initially for BRAF V600E mutated melanoma. And so we were chomping at the bit forever to get access to these drugs. And finally, a couple of basket trials were opened, including the ROAR basket trial that enrolled non-melanoma BRAF V600E mutated cancers. And here I show the data from 36 patients with BRAF mutated anaplastic thyroid cancer that were enrolled in this basket trial. Vivek Subbiah is the author of this study. And you can see that the objective response rate in these patients with anaplastic thyroid cancer treated with dabrafenib and trametinib is 53%. And the swimmer's plot here shows that a number of patients really can remain in response for a very long period of time. The median progression-free survival overall is 6.7 months, but still that's not bad at all for patients with anaplastic thyroid cancer. And so it was on the basis of these data that dabrafenib and trametinib were FDA approved for BRAF V600E mutated anaplastic thyroid cancer. So that's pretty cool. So it should work even better in papillary thyroid cancer, right? Naifa, this is your study. We studied dabrafenib plus or minus trametinib in BRAF mutated papillary thyroid cancers that had progressed. Patients were allowed to be previously treated, and a number of patients were. But here you can see the bars are color-coded for whether they were treated with a monotherapy arm, or the red bars are the combination dab-tram arm. And you can see that the objective response rates were 35% and 30%, not as high as with anaplastic thyroid cancer for some reason, with a median PFS of 10.7 months and 15.1 months. So perhaps dabrafenib plus or minus trametinib doesn't quite work as well as it does in anaplastic thyroid cancer. I think, though, that we can't make those kinds of conclusions and do study comparisons, but it is definitely food for thought. We do have an international phase 3 trial that has completed enrollment now, comparing dabrafenib and trametinib in BRAF mutated papillary thyroid cancer that's progressed on one prior therapy. And so in this study, dabrafenib and trametinib were compared to placebo with a primary endpoint of progression-free survival. So this study has completed enrollment. I'm not quite sure when it's going to read out, but I would expect that it's going to be reading out in the coming 1 or 2 years. So we had the study open here in the US, as well as in Canada, Mexico, South America. I didn't say Asia here. Oh yeah, Asia's there. There were a lot of patients enrolled in Asia. We did a terrible job enrolling patients in this trial, however, because while the study was underway, dabrafenib and trametinib did garner an FDA approval for any solid tumor with BRAF V600E mutations without other therapies. So it was difficult to enroll patients to this randomized placebo-controlled trial, but nonetheless an important trial. So what do we do here at MGH in terms of identifying patients for whom gene-targeted therapy is appropriate? First, I think it's important to say that gene-specific therapy in advanced thyroid cancer really is a precision medicine success story, and we need to take that to heart, because a majority of our patients with advanced thyroid cancer who are going to need treatment at some point will harbor a potentially targetable alteration. So we need to test every single one of these patients. We don't want to miss a single patient who harbors a potentially druggable alteration. So in the paper that we're talking about, we initially published a stepwise approach to looking at gene alterations in iodine refractory DTC, doing, if it's papillary thyroid cancer, doing immunohistochemistry or PCR for BRAF V600E first. And then if that's positive, your inexpensive and easy to do test gives you the answer that you need. And we would use generally lenvatinib in that patient population if a BRAF V600E mutation is found as first-line therapy, and then dabrafenib and trametinib as second-line therapy. And then in the paper, we called for germline testing for medullary thyroid cancer, which is really quite critical in every newly diagnosed patient with medullary thyroid cancer. But now that selpercatinib is approved, germline testing often takes too long. You want to do it in conjunction with genetics counseling. And so these days now, we usually go to somatic NGS testing first and circle back on germline RET testing for our patients. In terms of the NCCN guidelines, I won't go through this at length, but basically the NCCN guidelines do highlight that genomic or molecular diagnostic testing really is important for patients with advanced disease. I just picked out the one for papillary thyroid cancer here, but follicular thyroid cancer, oncocytic thyroid cancer, et cetera, are all the same. But the NCCN guidelines do highlight that you want to do molecular diagnostics and make sure that you're covering ALK, NTRK, BRAF, and RET fusions. They do call for looking for a mismatch, repair deficiency, microsatellite instability, and TMBs. This is based on the tissue agnostic approval for pembrolizumab, which we don't see these things in thyroid cancer. So I don't think it makes sense that they're incorporated into NCCN guidelines, but they are there because of the pembrolizumab tissue agnostic approval. But the NCCN guidelines do highlight that lenvatinib is the preferred first-line approach unless NTRK fusion is seen or a RET fusion is seen, and then larotrectinib, entrectinib, or repotrectinib are recommended, or selpercatinib or pralsetinib. So let me just highlight a quick case, and maybe this is a good place where Eric and Naifa can chime in. This is a patient we just saw a couple of weeks ago who came down from Maine. He had a right hemithyroidectomy. You can see he had a right paralyzed cord and a gel foam injection there. He had, before he got his radioactive iodine, he had this non-contrast CT scan done showing a significant amount of tumor burden. There's actually, it doesn't show it very well here, but there's a tumor on the left side infiltrating right through the thyroid cartilage there. There's tumor in the lumen of the trachea there, a high burden of lung metastases as well. The outside path report described a high-grade follicular cell-derived non-anaplastic thyroid cancer, so it sounded like it was a pretty good pathologist to me. We were chomping at the bit to get his outside path reviewed here, and it took forever. But he was admitted from clinic for an urgent tracheostomy tube and G-tube placement. We didn't want to wait for the outside path to arrive to let us be able to do molecular diagnostics in this patient who clearly needs good treatment right away. So we did a same-day core needle biopsy that showed a differentiated high-grade kinase fusion-related thyroid cancer. And the immunohistochemistries that were done included a pan-TRK immunostain that was positive, BRAF V600E immunostain that was negative, ALK immunostain negative, and then the Ki67% was 80, making me feel very nervous. And of course, we ordered our NGS testing right away. Maybe I should pause there. So, comments?
Naifa, Eric?
No, as usual, Lori does an amazing job. I think it was important that, pathology quickly ruled out anaplastic thyroid cancer, right? Because sometimes these patients don't necessarily know how fast it grows. They lose weight and, find this and think that it's rapidly grown. But I think that's important. And I like that you have, IHCs available for multiple alterations. The only thing I would add is we recently just did RAS IHC because a vast majority of thyroid cancers have either the BRAF V600E, which is what the IHC only tests for, on that type of BRAF, as well as RAS, and that captures majority of the thyroid cancers for a faster turnaround. Not necessarily that you need a rapid turnaround here. And also he wasn't coughing up blood or anything like that, but there is invasion. So we want to be careful when we think about those treatments and what to warn the patients.
Yeah, he also, I didn't say this here, he had developed a brachial plexopathy that had been emerging over just a few days. And, the CT was from October. He had a surgery in July. So even though it's not anaplastic, this was rapidly a progressive disease. So we started him on Larotrectinib on November 8th. And then his NGS testing came back on November 12th, and the solid fusion assay was negative, not showing an NTRK fusion, showing a KRAS mutation, Naifa, as well as PIK3CA, RB1, and TP53. So I called him up yesterday, and he's stopped the Larotrectinib. Another point that I'm going to pause. So should I not have started the Larotrectinib?
No, what's interesting is that pathology just reviewed this with us, and the IHC for TRK is catching non-targetable TRKs. And so we've stopped doing the IHCs because we found the same thing that what happened in this patient recently, that if it's not helping the targetable ones, we may be, starting the Laro. So very interesting. I'm glad you shared this with us.
Yeah, so I actually called our molecular pathologist right away and said, what's going on here? And they can take a look at the bulk RNA data, and there actually was activate a lot of transcription of NTRK in this tumor, and that's why we think that the pan-TRK IHC was positive.
So
I'm sorry, go ahead, Naifa.
No. I was just going to say it's mutations rather than fusion, it sounds like, right?
Yeah, so I don't know. Actually, there weren't mutations that were picked up on the NGS testing, though I don't know the operating characteristics well enough to know if they would pick up any mutation that might be, cause a little bit of upregulation.
Eric, can I grab you here for one of the questions from the audience related to whether or not ALK, NTRK, or RET mutations are potential redifferentiation targets similar to BRAF or RAS mutations. Would you be able to comment on that?
Sure. So, I mean, theoretically, you would think that these should be, and they're rare enough that we haven't really done good studies with it. As we've started to use some of these or more and more of these drugs, sometimes like off study, Laura Busaidy here has set up sort of a generic protocol to try capture all these times we try things that are being done off study, whether it's the typical RAS or BRAF target, or whether it's NTRK, RET, or even ALK, and we still only have a very small number of these patients that we've tried this for. We've had some success with NTRK. We've had some failures with NTRK. I'm sort of surprised how many failures we've had with RET, because I thought Selpercatinib would definitely do it more, and it has been reported to redifferentiate in a case study done in Europe. And then I'm trying to think we've tried an ALK, or we were thinking about trying an ALK, but I can't remember if we ever did. So theoretically, it should make sense. The big problem is it's hard to gather enough patients to really do one of these type of studies. And Lori's part of ITOC is I think their group has been trying to figure out ways to do this, and real-time data where you don't have to do like a specific study, more like what Laura's doing at our institution, where they're trying to figure out like ways to be able to gather this from all these institutions, knowing that to do this as a single study in these rare indications is probably just not doable, unfortunately. But like I said, it should work. We're trying to get enough cases that we can maybe see what the real chances are, but right now we really just don't know.
Eric, send
Great.
your RET fusion patients down to Boston. We have a clinical trial looking at sulpercatinib for redifferentiation. It's also open at Anderson.
Yes.
No.
Shameless plug.
Shameless plug, yes. It's open for all of us. So I just wanted to comment a couple of things. It's a very interesting question about the rediff. There's a couple of case reports, right? We need larger trials, which is why Lori's talking about the sulpercatinib trial. We need to look at this, like, what are the right type of patients, right? So if it didn't work in somebody, did we pick too bulky disease or too rapidly growing, or was there something or very FDG avid? So there's a few case reports for NTRK inhibitors. Even in a pediatric patient with first line, I think, right, there's 2 or 3, Lori. And then with RET inhibitors, there's case reports as well with nice responses. Like Lori was mentioning in her paper, it's exciting that the targeted therapies that have come out have deeper responses for longer time, right? And that's some of the differences. And it's interesting because all of us on this panel, when we started our careers, there were no targeted therapies FDA approved, not to age us but Dr.
Thanks, Naifa.
Dr. Rubinson was the only FDA approved drug, right, for thyroid cancer.
Yeah.
And now we have 11, like in the span of our careers, and we're not that old, right, guys?
Yeah. No, I mean, the field has been transformed, while we've been doing this stuff.
Yeah, and I really like the paper that Lori highlighted in the beginning that has a better definition of what advanced thyroid cancer is, because everybody grapples with that, right? And that list. And the only thing that I think we could consider adding to that is oh yeah, thank you, Lori, is for the rediff patients, right? How do we define those? And maybe it's not the bulky, rapidly growing, gross, disease patients. But other than that, I really think that, going forward, just like we came up with definitions for radioactive iodine refractory, we need to think about using these definitions in some of our trials and talking about these patients.
So
sorry, Mark,
maybe,
I digress.
Yeah, no. There is a question from the audience, but while you're on that subject, Lori, in your treatment paradigm that you have in the paper, maybe you can update us and all of the panelists can comment on, when do you try to see if you're getting a response? When does improved RAI avidity fit into the equation here? Is that an automatic, or do you reserve that? When do you do that?
So I think that's a really good question, and without a really good answer. And it's a really huge question in the field, and it's been very difficult to do clinical trials in that space that can really provide the data necessary to make this a standard of care approach. But so earlier on, when patients were on the decision trial or the select trial, we would occasionally do a whole body scan in patients, a diagnostic scan, to see if there's some redifferentiation going on. And then we could maybe take patients off the study and give them some radioactive iodine to try to make some extra progress. And it's a nice idea to couple a kinase inhibitor with radioactive iodine. Combination multimodality therapy is a long-standing way of tackling a difficult problem in oncology. And so it would be great to be able to do that with a kinase inhibitor and RAI. So those little experiments or one-offs didn't really work with the multikinase inhibitors, but we are seeing that patients on dabrafenib and trametinib, on sulpercatinib or pralsetinib, larotrectinib, can have iodine uptake when they previously, were stone cold negative. And you can, see there are case reports, and then a couple of phase 2 trials with dabrafenib and trametinib or dabrafenib plus other drugs that Eric has done for redifferentiation. And I think that we know that there's a there, that you can get tumors to take up radioactive iodine. In some cases, you can see those tumors shrinking up enough to meet criteria for resist response that's sustained. We usually use the 6-month mark as something that probably is associated with clinical benefit. We just haven't been able to do a large, you don't necessarily have to do a randomized phase 3 trial to show definitively that something works, but we haven't been able to do a large scale trial that has provided the kind of level of evidence for this to become a standard of care. And it's really frustrating. A number of us have tried to get those trials off the ground. And for, it's a rare patient population. It's really expensive to do this stuff. And we just haven't been able to fund those really important studies yet.
Eric or Naifa, do you want to comment kind of where that fits into your treatment paradigm?
Sure. Yeah, I mean, one like I think with like Laura, these are things we do need to figure out a study because we know we could increase uptake of RAI, and we know we could get responses like within like 6 months on scans, but we really don't know what the true benefit is compared to just not doing anything and just watching these patients. And are we really affecting either overall survival or affecting quality of life? It's more, to me, it's the most interesting part is like when you're actually treating a patient on dabrafenib or trametinib or selpercatinib or larotrectinib, and while you're treating them for their progressive RAI refractory disease, you see things that make you think this is redifferentiating. And to me, like the big things you always look for is tumor shrinking on the scans, but thyroglobulin going up. And to me, that's always like the big indicator that this is, a redifferentiation is going on. And that's where we talk, or at least I talk to patients about just doing an RAI scan while they're on treatment. And we've had a few patients who I would have bet $1 million before they start treatment that there's no way they would redifferentiate. They had like that type of aggressive disease up front, who did redifferentiation. We gave them RAI and then they got them off treatment for a year or longer than a year. Because of that. So it always like sort of surprises me. You could do that as a good indication of it, but whether this is really giving long-term benefit to people, I think is sort of the big $1 million question. And how to design these, a randomized study or something to really let us know what kind of benefit we're giving these patients is, I think, really sort of the next step to try to figure out.
You mentioned the patient going off of treatment for a year or so, as something that you might see with redifferentiation, and I do think that points to that really important endpoint of time to next therapy. And so you guys have started to incorporate that as an important endpoint in the idea of redifferentiation. And I would imagine as a patient that would mean a lot. So, would I rather have a course of treatment that might be 1.5 months long or 2 months long, and then be done with it and carry on with my life and keep going to my son's basketball games, then not have to be on treatment every day. That to me would be very meaningful. And I think that that's something that we want to remember when we're thinking about redifferentiation. It's a short treatment period that's pretty busy during that short treatment period, but if it buys somebody time off of needing other treatments, that's great.
So let me ask a naive surgeon's perspective here. What's the downside of doing a whole body scan if you have even an inkling that somebody may have achieved redifferentiation? Naifa, do you want to comment on that?
Yeah, well, yes, it's a great question. It's not a naive question. I just wanted to before I answer that, I just wanted to add to something that both Lori and Eric mentioned in terms of the rediff population, why it's going to be important to figure out what population, because when Lori showed the data of the newer trials showing treatment failure-free survival, right? It's not an insignificant number of patients that stop their lenvatinib, or, and it's smaller with the better targeted therapies. And so if you do get a patient, and even if they were on it for a year and then you thought about redifferentiation, do the whole body scan and treat with radioactive iodine, you take them off and do a short-term follow-up at 2 to 3 months. And if they're stable, if their disease is stable, you keep them off their drug. And we've had like a median of anywhere, like was mentioned, between 1 and 2 years, right, off of drug therapy. Quality of life is so important to keep in mind. So I think, to think about where are we going with this, I think people feel that if there are patients who, even if they have a little bit of redifferentiation, when they come back in that 2 or 3 months off of drug, they, their disease explodes, or their disease continues to progress, even if it doesn't explode. And it's probably the cells that didn't redifferentiate, right, that are continuing. I don't think it's redifferentiation that's causing that. I think it's the other cells that are now, coming through and growing. And so I do think it's important to define who are the right people, because we don't want to just keep giving radioactive iodine, taking patients off their therapies that are going to grow. And I think also where the field needs to move is, that first radioactive iodine treatment. There was a study called Astra that Alan Ho led out of Memorial Sloan Kettering that was done, that looked at, if we redifferentiate patients, at that time with selumetinib, before giving their first dose of radioactive iodine, do we decrease recurrence rates? And I think if we need to and that study didn't show that it was helpful to do, but I think we need to relook at the population, right? If we have BRAF IHC, for example, that's positive, or even if it's on NGS, do we want to give and it's extensive disease, are we really decreasing that recurrence with that dose of iodine? Probably not. Should we give those drugs first, right? And so I think that was some of the case reports that were shown with Entrec and RET. That I think would be important, and I wouldn't just take that as a negative study. So I'm not really answering your question. You can try it in patients. I think we're going to be doing it more and more. I just think that it's important to find the right population, so we don't just stop drugs, or not give longer term drugs, because the patient expectation at the beginning is important too.
I'll put in like the one like sort of caveat, and this is something just has to be studied more, is that Mabel Ryder put out something about some of these patients, developing anaplastic thyroid cancer. And the question is whether that's something that RAI, doing these redifferentiation would really push, which I don't know, or whether it's that just natural history of the disease. And, that's always a big question out there, is like, is the disease, when it comes back, is it more aggressive than if we just continue to treat them? And that's where like a randomized study would end up helping. Because I do know, like, we did have like one BRAF study here where when we looked at patients who had prior BRAF, a lot of them were part of redifferentiation studies. Those are ones that remain on the BRAF inhibitor for a shorter period of time than those who were truly naive and never were on a BRAF inhibitor. So, are you developing some resistance even being on a BRAF inhibitor for redifferentiation for like, 4 weeks or 6 weeks? So these are things that we don't know about. And, all the numbers are small. They all could be coincidence. But that's, I think, one of the areas that people have a little bit concerned. Can we ever be causing anaplastic come back earlier? And 2, can we be causing resistance to the drug later on when we try it? And, like I said, these are just questions, but they're questions from a very small number of people, which, easily could just be, variants.
Guys, I hate to say this. Lori, Naifa, Eric, thank you so much. We're up against, we are past the 9 o'clock hour. You guys have been terrific. As always, I've learned just an incredible amount, and I can't thank you enough for joining us this morning. Everybody have a great day, and stay safe. There's still some COVID out there. Be well. Bye-bye.
Thank you.
Thank you.
Thank you. Bye, everyone.